Hi, and welcome to the Subway Summit webinar series. My name is Tara Cunningham, and I'm the Senior Associate Dean for Student Affairs at the Icahn School of Medicine at Mount Sinai in New York City. And the medical schools in our region have been at the epicenter of the worst pandemic our country has ever faced. We have learned many hard-won lessons, and among them, the importance of finding ways to make the best of a very bad situation, and to transform disruption caused by COVID-19 into disruptive innovation. We hope this summit is a contribution in that vein, and that our ability to share how we've responded and what we've learned help our colleagues across the country, all of whom are facing COVID-19 challenges, some of which are universal and others that are unique to each of our institutions. This series is made possible from the contribution of New York and New Jersey medical schools. Each will share lessons learned from surge and post-surge recovery strategies and contingency planning with the lens of diversity, equity and inclusion, communication strategies, and infection prevention. Lastly, I would like to thank the colleagues across these participating institutions and the team at the Icahn School of Medicine that have made this webinar series possible. Your contribution, collaboration, compassion, kindness, and laughter have been absolutely needed in these last 3 months, and all the more moving us forward. A special thank you to Jeff Young at the Association of American Medical Colleges, the Josiah Macy Jr. Foundation, and the Associated Medical Schools of New York for supporting this effort. On behalf of everyone, we hope you enjoy the Subway Summit webinar series, COVID-19 Lessons Learned from the Epicenter.
So I'm going to reflect a little bit on what it was like in the earliest times of the COVID crisis, when it appeared like maybe we were going to be overwhelmed, that the New York City area was really seeing an unbelievable amount of cases, that there was an incredible amount of fear, and there were a lot of questions about whether we were actually prepared to be able to face something to this extent. It also made me think about an interesting thing. You know, when the medical school first started in 2011, we actually required our first class over the summer to read Albert Camus' book, The Plague. And it really, puts into context a bit about, what would you do as a healthcare provider when, in fact, faced with needing to care for people, and in a time when, in fact, your own health would be at risk. When you get complacent, when there isn't one of these things around, almost like peacetime versus being in the reserves, all of a sudden, maybe it doesn't really hit home immediately that, in a part, this is really what I signed up for. It reminded me also what I saw in the HIV epidemic, when there were some people who actually ran towards the enemy, for example, versus others who were hiding. And again, I'm not sure everybody really thinks that critically about, when I went to medicine, the extent of what that commitment actually means. But be that as it may, we have a big healthcare organization. I have a number of roles, including Chief Medical Officer. In addition to the Vice Dean, I'm also the Chief Operating Officer for Research. So we had a lot of different areas that we needed to take hold of. We were worried about our students, but mostly because, not that we were really worried about their health. We knew that we could protect them with PPE, but there were so many other people throughout the organization in the area who were clamoring about the lack of PPE. I thought we were doing relatively well, but it instilled an enormous amount of fear in various providers, nurses, and others, and it had an unfortunate outcome for our students who were basically told to go home, that this was too risky for them. I think others thinking that maybe they were actually using some of the PPE that was going to be potentially a shortfall for them. So with that, we hunkered down. We did what everybody wanted us to do, and we made it through. We had the opportunity as an organization to do what we called load balance. We moved thousands of patients from one particular area of the organization to another so that nobody did get overwhelmed. We had adequate PPE, and it really allowed all our frontline workers to potentially do the job that they wanted to do without the fear of being overwhelmed by numbers of patients and the possibility that they wouldn't be protected by PPE. So just so many things running through our heads, but the one thing was clear: we knew we were going to be learning. We knew that this was just another example of you can't predict a disruption, you can't control nature, and you will always have to react to the science. So fortunately, I think we're getting to the end, and it'll be a long, drawn-out tale, but the crisis in terms of being overwhelmed, fortunately, I think is behind us, at least the first go-around. Thank you.
Before we start this session, it's important that we take a few moments to talk about what's really been going on in the world around us. The COVID-19 pandemic has had a disproportionate impact on Black and Brown communities across the country. The violence that COVID-19 has done to communities of color, how different is it really than the violence that we're seeing on the streets in Louisville, Kentucky, in Minneapolis, and in southern Georgia? It is really part and parcel of the long history of violence in America against people of color. It is part of our legacy. And it is another sad piece of evidence that systemic racism leads to the unspeakable loss of life and is our nation's fatal flaw. Welcome, everyone. Welcome, medical education colleagues. We are so happy to see you here with us this afternoon, this early evening. This is a Subway Summit webinar series from the Epicenter, and we are so glad to have you joining us. My name is David Muller. I'm Dean for Medical Education at Icahn School of Medicine at Mount Sinai. If you have not joined us in previous sessions, we want to make sure that you know that there's a special session scheduled for Friday, June 12th, 6 to 7:30, entitled Racism, American Medicine's Fatal Flaw. We've put this session together over the course of the past week, given the circumstances that are surrounding us, not just in academic medicine, but in American society as a whole. And if you can, we really would love for you to join us Friday evening for that session as well. We want to also, if you have been with us the last couple of days, do a quick check-in before we do anything else. This is a brief statement on your part. In one word, describe how you feel in this moment. If you have not used Slido before, slido.com, you put that into your, on your phone and your computer, and the password is Summit. And you can type in one word and let us know how you feel in this moment. We'd love to hear from you. Exhausted and grateful and thankful. It's an interesting combination, isn't it? Exactly what we feel and exactly why we're here together today, why we've created this webinar series. Hopeful. It is good to be able to feel hopeful now that we're over the hump, at least in New York City, New Jersey, of the peak of the pandemic. We do feel drained and tired. We are curious too about what the future holds. We're curious about how this session is going to go and what we can learn together. And happy that it's warm. Yes, definitely happy that it's warm. And lots of things to be thankful for. Thankful for our colleagues, thankful for our families, for the people who've stuck through with us together in all of what's happened in the last couple of months. And interesting that hopeful is still kind of by far the biggest word out there. This is sort of hump day in the week and also hump day for the seminar series. So maybe we are past the hard part in the beginning and have lots of good things to look forward to over the course of the remainder of the week. So you can keep putting in your responses if you want. I'm gonna move ahead a little bit and talk about who we are. So you can see from this visual a little glimpse of what I guess we would call our neighborhood in New York and New Jersey, what we've also called the epicenter of the pandemic in this country. But who we are in addition to being medical educators and administration, we are people who have been meeting daily, multiple times a day for about 100 days now in 2 dimensions with our colleagues who we're used to sitting in the same room with, and sometimes patting someone on the back or giving them a hug after a particularly hard day. And we have really not been able to do that. We're people who have been sheltering at home. We're also people who have students. Every single one of us schools has students who have struggled with families that have lost income, families that have lost loved ones. Each of us in our own personal lives has been touched in many ways by the pandemic. There's an expression that we've used over and over again, many of us, I think, across the country. We keep saying to ourselves and to our students, these are unprecedented times. What does unprecedented mean? I think one of the things that it means is there has been unprecedented loss and unprecedented sacrifice that we've all made. At the same time, it has been unprecedented in terms of the ways in which we have all risen to the challenge. The pandemic, as awful as it has been, has brought out the very, very best in all of us. You can see from this slide all of the partners who've come together to present this webinar series. We have a lot to be grateful for in terms of the collegiality and collaboration we've had across schools. And in particular, we want to thank the Josiah Macy Foundation and the AAMC, AMSNY for their support and sponsorship of this meeting. And in particular, even though it has been a cast of thousands, literally, that's put this together, I want to point out Drs. Cunningham, Tara Cunningham, and Leona Hess, who really have kind of shouldered the burden of doing all of the creative work and the back end kind of logistics to make this happen. So the Subway Summit has a handful of learning objectives. They're up here and they're in your materials as well. I also want to say that all of the sessions all week long are being recorded. So if you have colleagues who have not had the chance to register or to get off of our waiting list to observe this, you'll be able to see them. They'll be able to see the sessions afterwards as well. On day one, we covered curricular affairs. We spoke very broadly about changes that we've had to make. We talked in curricular affairs about brand new initiatives and programs that we had to put in place. And we also talked a lot on day one about the curricular conventions that we've all sort of stuck by in medical education, sometimes because of inertia, and the need in many of those instances to get rid of those conventions and kind of forge ahead in a much more nimble way. On day two, we talked about student affairs, the importance of keeping our students on track, no matter what it took. We talked about the importance of maintaining our students' wellness. And we talked a lot about diversity and equity and the degree to which it's become more important than ever for our students as they've experienced this epidemic in medical school. And on the first 2 days, and I think as well as the rest of the week, we will talk over and over again about what will stick of the changes that we've had to make or the things that we've learned. What are things that just sort of were timely and we may never have to do again, and things that we discovered are a much, much better way of doing things than we've ever done before. I will mention that one of the things that absolutely will stick, I think there's no doubt in any of our minds, are all of the lessons that we have learned in the past about the importance of communication, the importance of collaboration, the importance of being inclusive in terms of the way we do our work, all kind of under the umbrella of leadership skills. Without that foundation, there's no way we would have made it through this process. Today's session is entitled Academic Health Center Leadership and Governmental Affairs. In the first 2 days, as I said before, curriculum and student affairs, we kind of used the microscope. We were down in the trenches with the people who did the work and built the building blocks that essentially reimagined medical school. Today, we're not going to use a microscope. We're going to use a little bit of a telescope. We're going to move out from the trenches, zoom out, so to speak. I hate to use that expression, and take a much broader perspective about what's been going on in academic health centers. You'll see on a national level, on a state level in New York State in particular, and then in some important academic health center missions. The panelists are listed here and in your programs. Karen Fisher from the AAMC is going to talk to us about the national landscape of advocacy and policy. Wayne Riley from Downstate is going to talk about the immediate and imminent resource crisis that we faced during the course of the pandemic. Eric Nessa from Mount Sinai will talk about research, opportunities and ramifications, and then we'll finish off with governmental affairs and a description of the sort of special consortium we have in New York State of all the medical schools. But before we do that, we want to do a little bit more of touching base with you and getting a sense of both where you are and who you are. We want to hear from you. So we're going to go back to the Slido function, slido.com, and password is summit, and just type in what city you're in. let's get a sense of the range of where people are coming from this evening. Brooklyn, Pittsburgh, Cincinnati, Westchester, Macon, Georgia, outstanding. Spokane, Valhalla. Teaneck, New Jersey. Mineola local, all right. Bethesda, Maryland. Tucson, Arizona. Long Island, keep typing in a couple more. Let's see where folks are coming from. Bethesda. Whoa, Indianapolis just got really, really big. Maybe you're just typing in big font. All right. So we have a sense that this is definitely a national webinar. People from all over the country are joining us today, and we are very grateful to have you here. Winston-Salem, North Carolina. We have one more Slido question to ask you, and this is not where you are, but how you are. On a scale of 1 to 10, how much has your professional and personal life been disrupted by the COVID-19 pandemic? Slido.com, Summit, and just type in a number for us on a scale of 1 to 10. This is the question that may have an obvious answer for many people, but we just felt like it was important to display for all of us as a community what we've been dealing with, even though this does not provide any detail, obviously. But at the same time, the reality of what we've all been coping with. You know, if this was a pain scale and our patients said their pain was somewhere from a 7 to a 10, I think we'd be very, very concerned and start to treat that right away. And treating it, you know, to some extent has meant a lot of wellness initiatives that many of us have had to kind of fold into the work that we do, thread into all of our meetings as best we can. So thank you very, very much for sharing that with us. We're going to move on to the presentations. And as I said, the first presentation is going to be from Karen Fisher from the AAMC, who's Chief Public Policy Officer, who will share with us some thoughts about advocacy and policy updates on a national level. Karen.
Right. Terrific. Thanks so much, David. And it's great to be on this panel with my esteemed colleagues. I'm going to give a little bit of a high-level, national level update, as David had mentioned, so that we can get to more specifics at the local level. As I think many people know, I think if we can go to the first slide, David. First, what I want to say, I'm so glad David finished up his discussion with the discussion about the issues surrounding George Floyd and his murder, and the issues surrounding racism, and the discussions that we've been having as a country, and particularly I think in many of our institutions. And just wanted to make sure people were aware that the AAMC also put out a statement. I know many academic medical centers put out a statement as well, and a number of organizations are actually endorsing our statement. But we certainly, as you had mentioned, David, in the midst of this COVID, have to take stock too at other issues that are affecting many of our fellow citizens, neighbors, families, et cetera, and us as individuals. With that, if we can turn to the next slide. In terms of COVID, it's not unusual when we see in New York, in New Jersey, across the rest of the country, the AAMC represents all the academic medical centers in the country. That's all of the medical schools, as well as all the large major teaching hospitals and their faculty practice plans. And it's not surprising that when you looked on the news, when you looked at what was going on in New York and New Jersey, the people who were treating the most of the COVID patients, particularly the sickest, were academic medical centers, whether they were Mount Sinai or SUNY or Northwell, as we saw at the beginning, et cetera. And in part, that's because you have a tradition and mission of treating the most complex patients. We have the most advanced technology, tend to have the most ICU beds and other types of issues. And we're focused on the research in that spaces. And I think when the previous speaker said running towards an issue, I think that's what academic medicine has done. And as the AAMC as an organization and located in Washington, DC, I think largely our role was to make sure that policymakers understood the role of academic medicine, but also understood the needs of academic medicine and your patients and what was needed for your patients. So as a result of that, we were very active from the very beginning in engaging with policymakers, including our CEO, David Skorton, who participated early on in a meeting with the Vice President and the coronavirus task force to talk about the needs. And I will tell you, he was at that meeting that there was a strong discussion about the need for the administration to declare a national emergency, which opened up a lot of opportunities and relief opportunities at that time. The other discussion, if you can remember early on, and I'm sure Dr. Nestler remembers this as well, was the critical need for testing at that point and the role of testing. And so in addition to that meeting, we had many discussions, particularly early on with the FDA, with all of the acronyms, FDA, CMS, ASPR, which is the Secretary for Preparedness and Response, FEMA, HHS writ large, the Coronavirus Task Force, et cetera, to talk about what did our institutions need to be able to treat the patients and what were needed by the patients, as well as then, of course, talking to the policymakers in Congress who needed to pass legislation to also help deal with this pandemic. So if you could turn to the next slide, David. For Congress, this was an extraordinary pace for the legislation that was developed and passed. As a reminder, this is a presidential election year, and in my world, as head of a government relations organization and someone who spent time in the Senate as a senior health counsel, election years generally aren't very busy. Most of the time, there's a lot of campaigning that goes on, and that certainly is not this year. And you can see sort of the timing of this, and then the ramping up of the types of money that we're talking about. And there's almost a story that goes along with each of these stimulus packages. The first really dealt with providing the NIH and their institutes with money for research, for vaccines, which was a critical part. There also was, we were very pleased to see some openings related to telehealth, that there was a recognition that if we weren't going to have patients, that we would need to open up some issues to be able to treat patients through telehealth mechanisms. The second package really then started to focus more on the patients, because we all recognized and heard from many of you, the last thing we wanted was for there to be any barriers for patients to seek treatment, to be tested. And as we start to see that over time, we also started to see, as people got furloughed and laid off, and given that their healthcare was connected with employers, that they were losing healthcare. The third package, which you can see really jumped up in terms of the dollars, $2 trillion, focused on the unemployment issue and small employers and what was going in the economy, but importantly, also provided a $100 billion provider relief fund, because there was a recognition by virtue of many of our members talking to their policymakers and by the AAMC, of course, that providers were being financially strapped in two ways. One was, particularly academic medicine, treating COVID patients, preparing for the surge, adding beds, all of the PPE, all of the activities needed to treat patients, and while at the same time having to cancel non-urgent procedures. And so having no revenue coming in and lost revenue associated with not treating patients, as well as the extra costs coming in. And particularly for academic medicine, that can be very difficult, because as many of you know, or on the phone, you're working at full occupancy rates under normal conditions. So it's not like when COVID opens back up that you were at 50%, you can say, well, we'll make up that revenue because we'll just amp up how hard we're working. You're at capacity and you're gonna go back to capacity. So that lost revenue really does get lost. There was then a recognition, and we advocated very strongly for Congress to recognize that there needed to be more money going into the provider relief fund. And you can see on April 24th, an additional $75 billion was put into that fund, as well as a recognition of the need for additional funding for testing. What was also very heartening during this period was the role of the administration, and particularly the Centers for Medicare and Medicaid Services, who affect so many of the regulations that our institutions operate under. And they were very quick after having discussions with us, with many of our members who could say firsthand, this is what we need. Here's the barriers for us to be able to treat patients quickly And they provided waivers, and they did it quickly, I have to say, particularly in the telehealth space. And I'm sure everyone on this call is at institutions who moved from very little telehealth to a lot of telehealth very quickly. And in part, that was because a lot of those barriers were removed. Now, I will tell you what we'd like to see is that those telehealth opportunities continue post-COVID, and I'll talk to you about that in a minute. On the next slide, David. So basically, when you look at these issues, when you talk about COVID, it really did hit all the missions related to academic medicine. The patient care, the needs associated with that, the medical research and testing. We know so many of our members are working on the research associated with treatments and vaccines and developing tests. And, you know, early on, particularly developing creative solutions to things like respirators, to masks, to being 3D masks, to swabs, to almost developing 3D swabs, etc. And then we also looked at the impact on our medical education institutions and what was happening there related to the students and to student loans, the role of residents and what was happening there. And then community collaborations. David talked about the impact of COVID on communities of color and the role there, and the Ways and Means Committee, an important committee at the federal level, just held a hearing last week to specifically highlight that impact. And we thought that was extraordinarily important. And a number of people who testified were from academic medical centers, which was so critical. And the AAMC submitted a statement talking about the important role of that. To the next slide, David. Unfortunately, there's still more to be done. And you may hear that the House passed a bill very quickly after that. The Senate does not feel right now inclined to move as quickly. The politics of this is, it's in part related to the economy now and what are the needs of the economy, and that may drive legislation, but we are working very hard along with all of our members, and almost all of our members have government relations staff, as Mount Sinai does, and others, and work very hard with our delegations to, again, tell the story, tell what's going on and what's needed. And you see here on number 2, research relief, and Dr. Nestler is going to talk a little bit more about the research, but I will tell you, I think that was an issue that early on, there was so much focus on the clinical side, and importantly and relevantly, but then we talked to our members and started to really understand what was happening and the impact on the research labs who had to shut down, maybe deploy other activities to the clinical side. What's the impact of that going up? And we've spent time with policymakers explaining the need that research activities and that there needs to be financial relief on that side. We are pleased that the House bill did include some money, not enough, but as a starting point, just the recognition that there is an issue on the research side is important. And I know Dr. Nestler will talk a little bit about that more. And again, you see, as more people are unemployed, the need to get healthcare coverage for patients. And as we're seeing, as states open up and we're seeing more COVID cases and the unemployment rate staying where they are, we feel very importantly about the need for patients to be covered. I talked a little bit about telehealth. We're also looking about the role of physicians, and you've seen it probably in spades in New York and New Jersey, about the role of physicians taking on other roles just out of necessity, and to make sure that, similar to the Good Samaritan rules, that physicians are allowed to do that without fear of any type of liability issues for something that is done unintentionally. We also have been focusing on residents and looking at student loans. You see the whole list as it goes on. Immigration, the role of so many people who are on visas and the role they have played in terms of providing care for COVID patients, and the need to make sure those visas were able to be extended, to be continued, et cetera. And you see other issues related to the health workforce, and then critically to public health. I think if once again, it gets exposed that this country has not invested enough in public health, and it's critical as we move on to contact tracing and go over the next 6 months, however long it takes to get a vaccine, the public health needs to be supported, And we know many of our academic medical centers have worked with the public health departments throughout this period to be able to help identify, test, treat, and that's going to have to continue. Those are the types of discussions we are having with policymakers going forward. This is a pandemic that I think has affected so many aspects of everyone's lives in that front. And I think what we can feel good about is that policymakers have responded. We need to continue to have them respond. And I think I'm pleased as someone who works for all of you as academic medical centers, how proud I am of the jobs you have done. And I would say when we talk to policymakers at the federal level, the appreciation that they have for all of the work that you and your colleagues have done to address this pandemic. So with that, I think that's my last slide, David, and I'm happy to pass the baton to the next presenter.
Thank you very much, Karen, both for your outstanding work at the AAMC and for laying a great foundation for the rest of the presentations. Wayne Riley, president of Downstate Medical Center, is going to talk next and telescope us a little bit deeply into what was going on the ground in his home area in Brooklyn in terms of the clinical resource crisis that we faced. Dr. Riley.
Great. Well, good afternoon. Thank you, Dr. Muller. I'm delighted to participate in this Subway Summit amongst our collegial medical school community here in New York City and New Jersey. I want to thank Drs. Cunningham, Muller, Nestler, and of course the terrific Chief Policy Officer, AAMC, Karen Fisher, for their work over the last few months and what they do throughout the year to support us all. I'll give you a perspective of having led a storied academic health science center here in Brooklyn, known as SUNY Downstate, now known as SUNY Downstate Health Sciences University. We are truly a university in that we have bachelor's degrees in nursing and ultrasonography all the way up to doctoral degrees, and we were awarded university status by the SUNY board last June in recognition of the breadth and depth of contributions we make to not only health professions broadly, but also patient care. Our teaching hospital is the University Hospital of Brooklyn. It was built by the legendary governor of New York, Nelson Rockefeller, for a grand total of $25 million in 1963. $25 million, ladies and gentlemen, will get you probably at this rate a 10-bed ICU. And ergo, that was one of the structural problems we had at the outset of the pandemic, is that we were dealing with a 1963 chassis in a sense, and we had to pivot and make some interesting resource allocations and ingenuity and innovation to get the hospital facility stood up to take care of patients once Governor Cuomo asked us to become COVID only, which we did on or about March 23rd. Our experience here in Brooklyn is, you've seen headlines. We've been severely impacted here in central Brooklyn, in Flatbush, East Flatbush, which is our home base, with predominantly Black and brown patients, predominantly Black. We've had over 2,500 patients walk into our door to get tested. The average age was about 74.2. The youngest patient we had was a 2-year-old with COVID. The oldest was 99.9. We had a number of patients who did end up on ventilators and did succumb. The resource issue that David highlighted that I spent a lot of time working on as the leader of our institution, I had to worry about our students. And working with all of our deans. We have 5 colleges and schools. We have a College of Medicine, Nursing, Public Health, Graduate School, and a School of Health Professions. So we have about 2,000 students total pursuing all the health professions, of which obviously the largest cohort is medicine. We have a very large medical school. I believe we're the largest medical school by enrollment in New York City, second in the state of New York. With over 800 students studying medicine spaced out over 4 years. So we had to, as all of you had to do who are involved in medical education, I know Dr. Cunningham and Dr. Muller had to do this at Sinai, we had to pivot. And we had to pivot to going mostly online or virtual. for the first year students. They were obviously February, March, just basically getting back at hitting their stride from the Christmas holidays, when we had to, based on guidance from LCME and AAMC, pull them out of medical education settings, both preclinical and clinical. So that was a pivot. That was a strain. I know my colleagues on the phone will tell you how many late night meetings and strategy sessions we had to try to make this happen. Intensive discussion with our students, obviously, having massive town hall meetings of 200 to 300 students via Zoom. They were concerned about their interruption in their medical education, its impact, obviously, on USMLE. Those of us who've been to medical school, you sleep, dream, and eat USMLE step 1 and 2. And they were very concerned about the impact to their academic progression. So as much as we could, we tried to, calm them down a little bit, allay their fears that we were mindful, the AAMC is mindful of how disruptive this is. We hope that LCME is equally as understanding of how disruptive this has been for all of medical education going forward, given that we do have our LCME site visit, by the way, next February. So the students, we had to pivot to the other students in the other schools, somewhat easier. Public health, we were able to obviously pivot mostly online fairly quickly. Not so much nursing and the other licensed health professions, such as PA studies, occupational therapy, nurse midwifery, et cetera, where again, those licensed professions do have heavy components of clinical activity, which we've had to recast and reconfigure. In terms of one of my frustrations is clearly the difficulty of getting testing stood up appropriately. And, without being too political, I will say that the federal standing up of the testing was woefully inadequate from day one. And even once they did get the testing regime somewhat functioning, from my perspective, there didn't seem to be an understanding that the testing resources in hotspots area, just not only in New York City, but I would argue in my hometown of New Orleans, had similar issues, that there should have been a surge testing strategy into the highest incidence and prevalence areas of the country to better detect and isolate and potentially isolate particularly in Black communities, the high rates of incidence and prevalence, which I think, again, was a missed opportunity. A manifestation of my frustration about that is that we were reliant, as many of you were, at least initially, until your own testing capability came up at Mount Sinai and other places, we were somewhat reliant on the New York City Department of Health to perform testing. So it was very common for us patients to show up at our ER with clear signs, symptoms, complex, consistent with COVID-19, which is not a difficult diagnosis to diagnose. It's a difficult diagnosis to confirm because of the testing problems. But we would have to call down physically. We have a 56-year-old woman here in the ER, short of breath, febrile, very much consistent with what we think is COVID. Can we test her? And 9 times out of 10, they'd say, no, you can't. And that was really, really frustrating when I knew we were going to be deluged with patients, that we'd have to go through this, kabuki dance with the New York City Department of Health to get tested until we could ramp up our own testing. Now, in parallel, we were trying to ramp up our own testing capability, but guess what? You couldn't get the machines. I had 2 signed contracts with Roche for a $500,000 high throughput machine to test. And both times it was a $500,000 machine, had the money, couldn't get the machine. To this day, on June 9th, I still don't have that machine. Very frustrating. And the word we got back from CDC was, rather from Roche, was that the Centers for Disease Control and Prevention were controlling the distribution of this scarce high throughput testing machine, which again is reflective of the fact that I thought that the testing regime from day one was a debacle. In terms of where we go from here, I've also been active federally. Karen, I had the wonderful opportunity to brief the entire House Democratic Caucus about about 3 weeks ago at the invitation of the House Majority Whip, Mr. Clyburn of South Carolina, who I've known for years. He called me. He had seen me on CNN or MSNBC, one of my appearances, and he said, will you come on and talk about the testing problem to the Democratic caucus and give some ideas about what we should be thinking about. So thinking about in terms of where we are as a safety net provider, safety net hospital in central Brooklyn, hotspot, a great medical education contributor to the city of New York State, the nation, and indeed the world, is, we need a new hospital. And I was very transparent about that. And you may have seen the front page New York Times story in April, above the fold front page, where we talked about the great work we did in spite of the fact that we had this 1963 building to negotiate. And so, Karen, I argued that in the fashioning of a next stimulus bill, which appears to be emerging based on Chairman Powell's report on the economy and Secretary Mnuchin's testimony today, I think there's going to be more momentum for another bill in August. I know you know it, but I've argued that, look, the president's interested in infrastructure. Well, look, it's not just roads and bridges. In an era of pandemic, it's also healthcare facilities, and that there needs to be a carve out for infrastructure for hospitals of a certain vintage. And I shared my thoughts with the Democratic caucus in terms of some reactivation of the old Hill-Burton Construction Act, which was a 1946 piece of legislation signed by President Truman post-World War II, because we didn't have enough hospitals with all these GIs coming back, that really turbocharged the construction of hospitals well into almost into the Carter administration. It kind of met its demise during the Carter-Reagan years because of domestic discretionary spending decisions. But that's a model that could be revisited to try to focus infrastructure improvements, particularly in academic medical centers serving underserved communities as we are here in central Brooklyn. So with that, I'll turn it back. I'm delighted to participate and thank all of you for the great work you've done, and also Joe, your great organization, keeping all of us very smart people at all these very great medical schools connected and collegial. Thank you.
Thank you, Dr. Riley. I'm impressed how in 10 minutes you managed to take us from individual testing on the ground in the emergency room to legislation going back to the Truman era. Really appreciate the wide scope of knowledge and experience you have. I'm going to pass the baton to Eric Nestler, a good friend and colleague here and Dean for Academic and Scientific Affairs at Mount Sinai, to talk about research ramifications and opportunities in the thick of the pandemic. Eric?
Thank you very much, David, and good afternoon, everyone. One of my roles at Mount Sinai is to oversee our research enterprise. And in retrospect, from that perspective, the COVID-19 pandemic hit us, me at least, like a tsunami in slow motion. On March 3rd, just 2 days after the first confirmed COVID-19 case presented in New York City, I went to an international scientific conference. That's how oblivious I was to what was percolating just beneath the surface. And upon my return on Friday, March 13th, I was planning to host a lab party at my New York City apartment for 35 people. I was all set to proceed when my wife made me cancel at the very last minute. It was over that next weekend, by Monday, March 16th, when it became clear to me at least what New York City was facing. And we began to make plans to ramp down all non-COVID-19 related research at Mount Sinai effective Friday, March 20th. And all medical schools in New York City followed pretty much the same timeline. During this ramp down period, we allowed more lab activity compared to some schools. Each lab was permitted to have skeleton crews, about 2 or 3 people per lab, that could come and go as they pleased. The goal was to maintain critical mouse and cell lines. Overall, it turned out we only ramped down our mouse colony by about 20%, whereas some schools in the area ramped down by over 80%. So we were able to maintain much more activity. And people were allowed to complete ongoing animal experiments. Meanwhile, we encouraged our researchers to do as much work as possible from home. And in general, folks responded well. The major concerns, of course, for graduate students and postdoctoral fellows was their lost time and for young faculty who are just getting their own labs underway, this devastating interruption in their work. But our faculty remain productive to the extent possible. We submitted about 10% more grants compared to this time last year. Our graduate students and postdocs analyzed data the best they could, and with their PIs, submitted lots of papers and review articles. We had our graduate students continue with their thesis proposals and thesis defenses by Zoom. And in fact, like all of you, our lives were taken over by Zoom. All meetings went to Zoom. These included work in progress meetings, research seminars, even whole department retreats were done remotely. And it was interesting, we've seen several-fold higher attendance at these virtual meetings than at the in-person equivalents in years past. One example is we started a new seminar series of having Mount Sinai faculty present their own research to our community, and that's been so successful and well attended that we'll be continuing the new venue even when we reach a new normal. And I think many other meetings will continue to be remote given the greater participation. Meanwhile, as I mentioned, COVID-19 related research continued unabated. In fact, we probably were proceeding at about 150% of capacity given the large numbers of graduate students and postdocs and research assistants from non-COVID labs who volunteered to do COVID work. And I'll just give some examples from Mount Sinai's research enterprise. I know other schools in New York have led many similar efforts. Florian Kramer and his colleagues in microbiology developed one of the first assays to detect anti-COVID-19 antibodies. The test is now awaiting FDA approval. Researchers under the guidance of Adolfo Garcia Sastre have taught us a lot about the virus, how it infects cells and replicates, and are working on vaccines. Miriam Murad and her colleagues in the Immunology Institute have characterized the immune response to COVID-19. And we've heard a lot about this in the news, where some immune mediators called cytokines contribute to disease pathophysiology, whereas others are helpful, they're ameliorative. Judy Cho and Emer Kenny and our genomics groups have been studying the genetic factors that make some individuals at greater or lesser risk for COVID-19 infection. And many groups around the city, including our own with Valentin Fuster and Jay Mako, recognizing a hypercoagulation syndrome in a subset of patients with COVID-19 infections. And this has led to the institution of anticoagulant therapy, which has saved many lives across our New York medical centers. And our clinical research teams involving Judy Aberg and many others are investigating new therapies for COVID-19. I'll mention two other initiatives because they're particularly important to us. Alex Charney, Girish Nadkarni, and Miriam Murad and others embarked on a massive informatics project to bring together all COVID-19 related data. So this includes genome sequencing to molecular characterization of patient samples like sputum, blood, and stool, to imaging data of body organs or tissue sections, to clinical and digital data, and even including autopsy data from those individuals who did not survive. And tremendous progress has been made from these machine learning, artificial intelligence related approaches leading to important publications. And this large effort will have ramifications far beyond COVID-19. Like many of our campuses, we have been interested for some time in creating integrated portals for all clinical data across the schools of medicine and hospital systems, providing ready access to any faculty member who has the needed approvals, so that this really represents one example of how COVID-19 will have a lasting positive effect on our research enterprise. Another example is in health disparities, which David highlighted at the outset. We are all very aware of the disproportionate health and economic effects of COVID-19 on underrepresented and socioeconomically disadvantaged communities. To address this, we created a new institute and launched a related task force under the leadership of Carol Horowitz, involving Gary Butts and many others, to invest in understanding what sustains such disparities and in devising innovative ways of doing much better, which we must do. And I should mention that all of these various efforts focused on COVID-19 were made possible by an incredible level of philanthropy that we were fortunate to receive. And we're just so grateful to the people in the community who stepped forward to make these efforts possible. It's sobering for me to think about the last 3 months. It feels like 5 years. When I was in medical school, which was over 40 years ago now, and first learned about the 1918 flu pandemic, I remember very clearly how my professors, my classmates, and I were all supremely confident that nothing like this could ever happen again in the modern era, given all of our biomedical advances. So it's a good lesson for the humility and hubris, unfortunate hubris and needed humility for humankind. And I hope we've learned our lesson. At the same time, there's no doubt that our pandemic has provided a very rare opportunity, we hope once in a lifetime opportunity, to characterize and advance the understanding and management of a new disease. Meanwhile, we are literally on the other side of the peak and beginning to open up our research enterprise. Our lab research went to 25% normal human density on May 18, and clinical studies involving direct patient benefit got underway at the same time. We're 3.5 weeks into that experiment, and I'm very happy to report 0 COVID-19 cases coming from our research groups, which has given us great confidence. This is, of course, consistent with our data and others over the past 3 months that healthcare workers and people doing COVID-19 research in the New York area, and Governor Cuomo has commented on this, displayed lower rates of COVID-19 infection compared to the general public, showing that our PPE and related precautions really do work. Based on this encouraging data, we'll be ramping up to 50% research density this coming Monday, June 15th. And that really translates much closer to 80 or 90% effort, because people spend so much of their time away from their lab benches. And we're now ramping up other clinical trials, including those that do not involve direct patient benefit as well. So finally, after about a 3-month interruption, our research workforce is coming back. So we're making progress, and we look forward to seeing our research enterprise and New York City more generally getting back to work and coming back to life. Thanks, David.
Thank you. Thank you very much, Eric. I think the research enterprise may arguably be the best example of something that came to a grinding halt and pivoted very, very quickly and effectively to make the most of a really, really bad set of circumstances. And now the opportunities, as you say, abound. Joe Wiederhorn is going to spend some time talking to us about AMS-NY, which is just a unique situation we have in New York State, bringing together the medical schools across the state. And I think it's fair to say without AMS-NY, I'm not so sure that we would have made it through this intact and collectively kind of put our energies behind dealing with the pandemic. So Joe, very happy to have you on board with us today.
Thank you, David. I really appreciate being here and talking about our experiences as a consortium during this pandemic. Before I begin, let me just tell you a little bit about who we are. The Associated Medical Schools of New York, or AMS-NY, represents New York State's 17 medical schools. Our board of trustees are the deans of the medical schools, and the organization basically focuses on 2 areas. One is advocacy, and we do that, 90% of that we do in Albany, the state capital, and diversity in medicine, and we oversee 7 diversity in medicine programs trying to increase or diversify the physician workforce, which is as everyone knows, is very important, but is particularly important here in New York City. As for the 30,000-foot sort of look at New York's medical education, at any point in time, there are over 11,500 medical students in New York, and this is just undergraduate medical education. It doesn't include residency or postdocs at all. It's just UME. We have 17 medical schools, as I said. 5 of them are public, 2 of them are osteopathic, and the rest are private. So medical education actually here in New York is a very important driver of the economy as well as healthcare and healthcare outcomes. So I think I first realized that this pandemic was hitting probably right the week before match day. It was at that time that our Committee on Diversity and Multicultural Affairs started doing emails among themselves, trying to figure out what they were going to do about or about revisits for diverse applicants, whether they were going to still have them come to the schools or whether they were going to do things via video. And then I started getting emails from the deans saying, what are you going to do about match day? Are you going to, limit whether or not families can come? How are you going to, this is a time, as you all know, when there are a lot of people who are in a room together, celebrating together, and how is that all going to work? So those were really 2 big indications to me that medical education, as we have known it, was coming to some kind of an edge here that was going to need to be crossed. At the same time, the governor made an announcement. He asked that all retired physicians, nurses, other healthcare workers consider coming back into the workforce. And that the same healthcare workforce from other states, please come to New York. We need all the help we can get. So when he made that announcement, I got a call from one of the deans saying that they were really interested in graduating their fourth year class early, because they wanted to be able to put these students in to the hospitals to help. So he wanted to know whether or not other schools were thinking of doing the same thing. So we had a call with our executive committee, 6 of the deans, and there was a lot of hesitation about doing it, frankly. What's going to happen to these students? Where are they going to live? Because a lot of the students in a lot of the dorms were closing and people were going home. Who are they going to report to? What's going to happen to their financial aid? That was a very big one, because once they graduate, their financial aid stops, and yet they still had expenses. They would still have expenses. What's going to happen to their residency program? So there was a lot of, well, we're not really sure what we want to do at this point. And then one of the schools who had an inroad with the governor's office mentioned to his contact in the governor's office that we were thinking of doing this. And the governor became very excited, thought this was great. Eventually he started calling them the COVID-19 warriors. We're going to have this young group of enthusiastic, young, newly minted MDs who are going to come and help out in our hospitals. So at that point, we had a meeting of all of the deans, and we had some of the medical education, David was there, some of the medical education deans were involved in it as well. And we started talking about, well, now we're sort of forced to do this because now it's become the governor's thing. And, how can we do this in a way that makes sense? So the first thing I did was call the LCME, and Ronnie Cantonese was very helpful. She said they were coming out with a guidance and that as long as the students had 130 weeks of education, and as long as the students met the goals and objectives and core competencies that the medical school has said they need to meet in order to graduate, the students could graduate. So I asked her for a letter so that, you know, I could send this to the deans and they could have something in writing. So actually the very next day I got a letter from her laying this out. I was really pleased about that it happened so quickly. And I sent it off to the medical schools. And they, during that time, were thinking about, okay, so how are we really going to do it? What if not all the students meet these requirements? What if not all the students want to do this? You know, what is really the implementation strategy for getting this done? And then the New York Times ran a story on NYU saying that NYU was graduating their students early and that they were then going to be able to go into the hospital and help them in the emergency room and on the medicine floors. Well, that precipitated a call from the state education department who said, wait a minute, you just can't do that. We're the ones who will let you know whether or not you can graduate your students early. It's not the LCME, which really surprised us because the state education department is known to just rubber stamp what the LCME does. And so we, quite frankly, didn't think it was going to be an issue. But lo and behold, it was. Therefore, we started working our contacts in the governor's office, explained that, you know, this is something the governor really wants, but we've got an issue here. We need the state education department to approve this and to do it rather quickly. So they got on the phone and helped push the state education department, so that eventually what the education department did was they developed a attestation form where each of the deans had to sign off saying that their school is meeting the requirements of the LCME to be able to graduate their students early. The one thing they had on there that was new was that each of the schools had to ensure that their students who were graduating early were aware of the financial implications of it. And, you know, we're going to be talking to financial aid, particularly if they had a federal loan, we're going to be talking to financial aid people on the federal level. So all of the schools did that. The education department said when they get it in, we'll turn it around within 24 to 36 hours and you will be able to graduate your students early. And I, frankly, took a victory lap, thought, all right, this is great. We got it done in a week and everybody's happy, except of course, not everybody was happy. So after about 2 days, I get a call from one of the schools saying that the lawyer from the hospital says that the students can't go into the hospital. What are they? First of all, they won't be students. They'll be newly minted MDs. So they're new MDs. They don't have any kind of a license. They don't have a temporary license. They don't have a permanent license. We just can't put unlicensed physicians into the hospital. Who's going to take care of them? Who's going to oversee them? How is all of this going to work? So that posed, quite frankly, a much bigger problem than the early graduation problem. The problem that posed was that there needed to be state law that needed to be changed so that these newly minted COVID-19 warriors could work in the hospital system. And for that to happen, the governor needed to do an executive order saying that this is important. You know, after everything that had happened up to that point, I thought, well, this won't be that difficult. The governor was putting out a new executive order every day, so that shouldn't be that difficult. But it turned out that it was. We had to work with them over the course of about a week and a half, continually working with them, with the Greater New York Hospital Association, which is the biggest hospital association in New York, working with Greater New York, with the governor's office, with the state education department to pin down exactly which part of the statute needed to be changed, how it should be changed, what the language should say. And then we actually were able to get that done. The governor made an announcement, and the students could, or the newly minted doctors could go into the hospitals. However, it was right around that time that the ACGME came out with their guidance and suggested that students not graduate early. And they, I'm sure you all know, they had a number of reasons why they thought that this should happen or shouldn't happen. And then we had the issue of not really convincing the students, but we had to work around the issues that the ACGME posed. So first of all, the students could not, the young doctors could not be supervised by residents because residents can only supervise students. And so who was going to supervise them? And it was determined, you know, well, they're just going to be part of teams. They'll be part of a team. They'll be an attending. There may be a resident or not, but they are going to be well supervised, and there shouldn't be an issue about that. Well, who's going to take care of what happens if they get sick? Who's going to take care of that? Are they going to get paid? Where are they going to live? What about liability issues? And all of this was worked out between the hospital and the medical school and the hospital. And so we were able to then work around some of the problems that had been brought to us by the ACGME. The final thing was really what happens with students in their residencies. So those students that had matched to a New York City or a New York State hospital, they could go there, they could work as COVID-19 warriors, and then on July 1st start their residency program. But for those who were going to residency programs in other parts of the country, it was agreed that they would stop their work 2 to 4 weeks early so they could quarantine, because at that point everyone from New York needed to be quarantined when they went someplace else, so they could be quarantined there and then start their residency programs on time. So that was really, that's the process that we went through. During the breakout, if you want, I can go through the process of reopening the schools, because that too was a process. But really, we were very pleased. Starting April 1st, the first school graduated their students early, and before the beginning of May, they all had. So I just want to thank you all. That was great, and hopefully I'll see you in a few minutes.
Thank you very much, Joe. So for the audience members who are there, here is the information for the breakout sessions. If you want to speak to Karen Fisher a little bit more detail about national advocacy and policy initiatives, to speak to Dr. Riley about the resource issues and infrastructure that he described in his talk, to speak to Dr. Nessler about research opportunities forthcoming and some of the challenges we faced, and to speak to Joe Wiederhorn a little bit more detail about the unique structure we have for the Consortium of Medical Schools in New York City. The speakers will have until 5:30 for the breakout sessions. It'll be followed by the medical student webinar session, which we encourage you all to join. It'll be a thought-provoking sharing of perspectives from, we know, the next generation of physicians and scientists, advocates, and activists. We look forward to their session, and we look forward to seeing you all tomorrow at the session on operations, people, money, space, at 4 p.m. and hopefully you have the information for that. So thank you all very much. Thank you to the panel of speakers, and please join us in the breakout rooms until 5:30. Good night.
Thanks for having us.
Thank you.